again is our monthly meeting, cardiovascular conference. Welcome everybody. So this month is vascular surgery. Yeah. So this month's vascular surgery basically hosts this conference for this month. So we have two topics this afternoon. First is critical limb ischemia endovascular versus surgical treatment by Dr. Tan. So you all know Dr. Tan is assistant professor with vascular surgery. And the second talk, I think, is contemporary treatment of venous disease, and will be presented by Dr. Coder, again, as assistant professor from vascular surgery. Okay, thanks.
So thank you for coming again. So I'm going to talk a little bit about critical limb ischemia and go through some evidence comparing endovascular and open intervention for CLI. And the main thing that I want to talk about is the BASIL Trial that we are part of, and we are very excited to be part of. So quickly, overview of CLI. So this is a very significant problem in the US. And the cost that Medicare spend on CLI or PAD in general is rising every year. And I think now it's the second or third largest cost for Medicare after coronary artery disease. As we know, it's a main problem, and it can be associated with high rate of amputation or limb loss, morbidity and mortality. For people with CLI, if we not treat them, about 40% of people will lose their limb. So that's how high it is. And the annual mortality for these patients approach 20%, either secondary to other comorbidity, including cardiovascular or stroke, as well as the complication arising from the treatment itself. So when we talk about CLI, it's a very specific group of patients that we talk about. These are the patients who have rest pain or tissue loss, so either gangrene or ulcer, not claudication, not those with changes in ABI but asymptomatic. So these are a very specific group of patients that we talk about. We also have objective criteria. So these patients, when we look at ankle pressure on non-vascular lab, should have less than 50 millimeters of mercury for rest pain or less than 70 for tissue loss. For those patients who has highly elevated or falsely elevated ABI or pressure because of diabetes, when we look at toe pressure, it should be less than 30 for rest pain and less than 50 for tissue loss. There are different classifications that we use for CLI or PAD, and the Rutherford is the main one that we use. So we are talking about Rutherford category 4 to 6, not 0 to 3, okay? So rest pain, tissue loss. So this is one of our typical patients, 52-year-old female with sign of chronic ischemia. You can see on the right side, the patient has hyperemia from chronic ischemia as well as toe gangrene. Her ABI is 0.3 on the right side. And these are very typical. So for people with rest pain or tissue loss, usually they have multi-level disease. So when we say that, that means they have, oops. So as you can see here, so we're generally talking about infrainguinal disease. So they are disease in the common SFA, popliteal, and tibials. So they are generally multi-level disease. The treatment for these patients are complicated. The primary goal is relief of pain because they have rest pain. Try to heal the wound. After doing all that, try to preserve the function of the limb. So for patient who doesn't walk, there's not a lot of point of us doing aggressive treatment. And eventually trying to maintain ambulatory status. Like we mentioned, these patients has a lot of cardiac and cerebrovascular disease. So during the treatment, they have a lot of complications. The main role is try to minimizing the risk of mortality and the complication during intervention. For appropriate patients, this includes timely and effective revascularization either with endovascular or open bypass. So what do we do? Open or endovascular? So traditionally, we do open bypass. We can go from the groin all the way down to the ankle, as you can see. This is a femoral DP bypass with vein. For the last 10, 20 years, there are more and more endovascular intervention, including cryoplasty, atherectomy, PTA, stent placement. So which one is the best? When you look at the data for the last 10, 20 years, we know that endovascular take off, bypass drop down. Another thing is there are change of specialty treating PAD. There are a mixture of vascular surgeon, cardiologists, and radiologists. So which one is better? When you look at all the data nowadays comparing endovascular and open bypass for critical limb ischemia, they are mostly retrospective, small case series from single or two institutions. They are poorly controlled. Usually they have suboptimal endpoint. A lot of these are sponsored by device companies, so they have a lot of biases. And a lot of these patients, when they study the data, they include claudication. So traditionally, we use open bypass, but these are the complications associated with bypass. These are the data that we gain from two multi-center control trials evaluating open bypass. So you can see 3% 30-day mortality, 5% stroke, amputation rate 2%. When you look at 1 year, about 12% of people, despite us doing everything, including bypass, they lose their limb. And they have a lot of complications. So about 23% of people actually die at 1 year. Is there any level 1 data comparing different treatment approach? So this is the only one that we have currently in vascular or intervention world, which is the BASIL Trial. This is a European trial. They randomized 452 patients from 27 hospitals to surgery versus endovascular. The main technique that they use for endovascular is PTA, so they do not look at atherectomy, they do not look at cryoplasty or other new technique. This was published in Lancet 2005. The aim of BASIL Trial is to compare the outcome of surgery versus angioplasty. The result, there are no difference between two approaches at 5 years, at 2 years and at 5 years. This is important. There are trends towards benefit for surgery if the patient lives longer than 2 years. And we are talking about bypass using vein. When we use PTFE or prosthetic, they do pretty poorly. In fact, some of them are even, the outcomes are worse than endovascular. Now, this is an important point. When we do endovascular, we think that because it's minimally invasive and the morbidity and mortality after endovascular intervention is a lot lower than open surgery. That's why we use endovascular. However, people who had endovascular intervention and fail, they do worse, even if we go in for open surgery. So these are the graphics showing the thing that I talk about. When you look at amputation-free survival, at 5 years, they are very similar. Mortality and mortality are very similar between two interventions. So the idea of endovascular is better, at least in short term, is not really true because these are sick patients. Most of the mortality are in perioperative period. So these patients, even if you put a stent in or atherectomy, they have significant mortality and morbidity. this is the only level 1 evidence we have in this field. There are a lot of limitations for this trial. Only 450 patients, so very small groups. There are a lot of crossover. So, for example, the group of patients who has endovascular intervention, a lot of them fail and cross over to open surgery. It's not true for the other way, but they cross over. Endovascular therapy, because this is 10 years old or 15 years old data, the only technique that they use is angioplasty. So they do not use the newer technique that we use nowadays. They include all the patients. So SFA, popliteal, tibial disease, they are included in one group and analyzed. So that's the main criticism for this trial. And the primary endpoint that they use are mortality and amputation-free mortality, which I'll talk about a little bit, but I think a lot of people think this is suboptimal primary endpoint that they use in the trial. However, this is the only level 1 evidence for this group of patients. So that brought us to the BASIL trial, which we are part of this. This is a multi-center randomized control trial that started in September this year. This is the best endovascular versus best surgical therapy in patients with critical limb ischemia. The main objective is to compare the outcome of best surgical and best endovascular intervention. This is an important point. The patient that is included in this trial has to be candidate for both endo and open intervention. So when we look at the angio, we have to say that this patient is suitable for both intervention. It cannot be just for one. This patient has to have acceptable surgical risk for open surgery, even if they are in endovascular arm. And this is determined by us, the people that are treating them. So BASIL trial is a prospective randomized multi-center open label trial. The plan is 2,100 patients, so a lot bigger than the BASIL trial. The plan is 120 sites. There are 2 sites in Louisiana, and we are one of them. The plan is for 4 years, extending from 2014 to 2017, with every patient having 2 years of follow-up. And this is funded for $25 million. So this is what is important. It has to be a in a single institution, it has to be a multi-specialty approach. So involve us, the interventional cardiologist, the radiologist, and in some hospital, vascular medicine specialists. This is important. The best treatment is decided by us. So for example, if the patient is randomized to open surgery, we decide what is best, not the central committee. So if we think that patient benefit from a vein bypass, we go ahead and do it. Same thing goes for endovascular arm. So once they are randomized in endovascular arm, the technique that we use is up to us. So if we think that we have good outcome with different technique, you can use it. They don't really limit us for that. So same thing for open bypass. 2 cohort, one is with open surgery versus endovascular for patient who has suitable vein. So this is the majority of the patients, 1,600. And second group are those that do not have vein for bypass, although they can use different conduit, including arm vein, short section vein, prosthetic vein, and cryopreserved vein. The outcome that we are collecting is MALE, which is major adverse limb event-free survival, defined as above ankle amputation. So any BK or AK, major reintervention. So for example, if you're endovascular arm and you jump over to open and need a bypass, it's captured in these outcomes. Major reintervention including open, thrombectomy, thrombolysis. Other secondary endpoint are these, so reintervention, amputation-free survival. We are going to collect the functional and quality of life endpoints too with this trial, and the cost as well. So inclusion criteria for the trial: 35 years old, infrainguinal disease, so not the inflow, just infrainguinal, patient with CLI, judged by us that is suitable for both open and endovascular intervention. Has good inflow and outflow for us to do bypass or endovascular intervention. So like I said, they have to have enough inflow demonstrated by pulse, good triphasic signals, or the images showing that there's good flow to the common femoral. That's good now. Now, this is important. If the patient has inflow and infrainguinal disease, and we need to do inflow and then the bypass, we cannot enroll patient into this. So these patients has to have adequate inflow. So pulse, and then we do the bypass or the endovascular intervention. We exclude patient who is TAS A, has common femoral artery disease, popliteal artery, aneurysm, high risk for open surgery, hypercoagulable state, and acute limb ischemia. I talk about the inflow. So you cannot do the inflow and the bypass or the stent at the same time. But if you do it more than 6 months ago, you can enroll patient. So as long as more than 6 months ago, the idea of this is they want to look at the infrainguinal intervention and want to take the inflow out of the pictures. They don't encourage staging. So for example, if you do endovascular intervention SFA and you think the patient is on the table for too long and you want to stop and bring them back, usually they are not encouraged. They encourage us to do it within the same stage. So same goal for bypass. You don't take patient back, you just do it in the same stage. So the main thing about this is, number one, the patient needs to have good risk for open surgery. So we need to know that the patient has a good surgical risk. And we need to know whether the vein is suitable for bypass before the randomization. So these patients should have vein mapping before they go for angiogram. They actually encourage a multi-specialty approach. For each patient, we actually have to talk to cross-specialty or another physician from the same specialty. And whether they are suitable for open or endovascular intervention is decided by us, not the central committee. So we are very excited that the trial is coming over, as long as I think our hospital and the UH and the LSU sign the research agreement, we'll go ahead. So that's the main issue. Any question that you guys want to ask me? I think the main thing is because we're involved in the trial, and I want to give us an overview of the trial. And hopefully, once we started, we need to enroll 1 patient per month. That's their target for the NIH for this trial. Questions?
Very provocative study, which is very well thought of, and hopefully well done. But you think that they can answer some questions that we are basically raised.
And this is the largest NIH-sponsored trial for the last 10 years since the BASIL. So this will be a landmark trial, and I think we should be part of it, right?